Philip? Can you see my notes, my actual notes for myself?
So we do.
Now. Thank you. I'm so relieved. I was having trouble figuring it out.
I think we're ready to begin whenever you are.
Was Monica able to jump on?
We've joined her, we've added her right now. Yep.
Okay, perfect. All right, good luck, everybody.
So Elva, you will start the presentation?
Yes. Are we ready to go?
Yep, everyone's seeing your presentation. Please feel free to get started.
Okay, thank you. Hi, everyone. On behalf of our speakers in this session this morning and myself, we're thrilled to be participating in this conference. I'd like to acknowledge and thank our conference hosts for organizing this virtual event. I'm sure it was not an easy undertaking. So welcome to all of you, our audience, and thank you for joining us. Again, my name is Elva Tomashiro, and I am a child and family specialist in Los Angeles here at Children's Hospital Los Angeles. And I have the honor of introducing each of our panelists. I will be starting our discussion off and will be followed by Natalia. Natalia is an RB survivor. She is a registered social worker and works as a clinical therapist with children and youth with complex mental health needs in Canada. Following Natalia will be Monica, and Monica's most important role is being the mother to 3 daughters. She is the parent of a retinoblastoma survivor. In addition, Monica is a TV journalist, and along with her husband, is the founder of CAPS. Our last speaker is joining us from Nairobi, Kenya. Philip Odio is the patient support manager at Faraja Cancer Support Trust. He is also the director at International Psycho-Oncology Society, where he represents Africa. For his role in developing psychosocial programs in Kenya, he was awarded the Naomi Stearns Fellowship in 2018. Philip received his clinical training at Memorial Sloan Kettering Cancer Center in New York, and he is a fellow at the Union for International Cancer Control Fellows. So now that you've learned a little bit, excuse me, about each speaker, I'm going to begin our session by introducing psychosocial and emotional aspects of retinoblastoma and also identifying some of the stages of support. Like all of you, we've learned so much from our families in the retinoblastoma community. They've taught us that the diagnosis of retinoblastoma affects not only the child, but the entire family. Our work at Children's Hospital Los Angeles is built around the model of family-centered care. On this slide, I have the diagram where we're looking at the child and family in the center, or the core of our work, and surrounding the child and family, we have the medical team, medical specialists, and the psychosocial team surrounding the family as they begin their journey through retinoblastoma. So, what is psychosocial support? Psychosocial support is caring for the mental and emotional well-being of the child and family, one of the most important parts of what we're reminded of every day. So what does this support include? It includes assisting patients and their families with the psychological and social adjustments to their illness. The retinoblastoma program at Children's Hospital Los Angeles is an interdisciplinary team model, or a team approach, and it includes the medical specialists, our two ocular oncologists, Dr. Jonathan Kim and Dr. Jesse Berry. We have hematology oncology specialists, nurse practitioners, social work, and of course, child development specialists. I'm a little bit favored to that. As mentioned in the earlier diagram, our interdisciplinary team model is an example of what family-centered care can look like. Now, in other parts of the country and other parts of the states, family-centered care can look different. It can include more, it can include less. But I think the goal of this is that the child and family is at the center of our work. Support also includes education and guidance about diagnosis and treatment. Another form of support that we provide, of course, is preparing the child and family and siblings for visits to the hospital, tests, procedures that include exams under anesthesia, medical treatments, learning about chemotherapy, and in advanced cases, enucleation surgery. For those who have faced enucleation surgery, we also want to provide information and preparation about going to the ocularist and preparing the child for their prosthesis fitting. We're lucky to have Monica on our panel, who will be sharing her experience as a parent, explaining retinoblastoma to her child and to their siblings. She's going to be touching on the needs of siblings. We don't want to forget siblings in the mix of all of this. Of course, they're just as much affected by the diagnosis. And then transitions and return to daily activities, school, and survivorship. So what I've done to kind of categorize areas is looking at the different stages of support that we see in our experience. I've introduced the key areas of providing psychosocial support. And so now these are the different stages that we tend to see our families in. So diagnosis, treatment, education and child development, and transitions and survivorship. At time of diagnosis, and we are really getting to know a family, and a family is getting to know us and taking in all the information, which can be overwhelming. It's important for us to be aware and to remain aware that families come to us with their cultural influences, their belief systems, and their faith. Philip is going to be touching on the cultural and social needs in his work that he's doing in Africa, because that could really be a whole session in itself. But every family that we work with, we recognize that they have their own individual needs. One of the most important roles that we play during diagnosis is providing emotional support to parents as they are coping with the diagnosis and going through the grieving process. I know many of you in our audience understand this, the feelings of shock, denial, bargaining, feelings of guilt, anger, depression, and above all, hope. One of the things that we try hard to support families in is understanding and allowing parents and caregivers, allowing them to have their feelings of grief And in time, we know that when families go through these different feelings of grief and loss, that it really helps the child and family adjust to the retinoblastoma diagnosis. Within the treatment plan, we're providing parents with information about their child's care plan. We're preparing children for medical treatments, their EUAs, chemotherapy, and if necessary, enucleation surgery and visits to the ocularist. Another stage of support that we want to offer families is education and development, education around child development issues. So we're providing guidance to parents in addressing their child's development, and in some cases, they may have some vision needs. So this is where we would be looking at school and vision support services, understanding a child's visual acuity and their functional vision. How does this child use their vision to learn, to get around in their community? And then, of course, how to talk to your child, your community, and school about the retinoblastoma diagnosis, vision loss, and life with a prosthesis. The last area of support I want to mention is transitions and survivorship. This is where we're connecting families to vision services that may include early intervention programs, school district vision services. In our state, we have regional center and supporting youth transitioning services to Department of Rehabilitation. And of course, a life survivorship program. Transitions are what I like to call touch points with families. These are some of the common times after treatment is completed and child and family is only coming for their yearly visits. These are some of the moments where we have touch points with families. So they usually occur during the elementary school years. This is when the child begins to become self-aware and questions and curiosity from peers may begin. And then another touch point with families might be during a transition to middle school, a time where self-advocacy is really important, that they're practicing. And then another transition is during the adolescent years, high school, entering college, and important to be sure that the child who has survived retinoblastoma is introduced to support systems within a survivorship program, so that can continue. All right. I'm going to end my presentation with talking about what is it that we are trying to achieve by providing psychosocial support to our families. So achieving healthy psychosocial outcomes for us would mean the ability for a child and family to manage and foster coping skills during hospital and clinic visits. We want to nurture family dynamics and communication within the family unit throughout their treatment, their visits to the hospital. We want to assist parents in having honest, age-appropriate communication with their child and sibling about the diagnosis. We want to guide parents as they encourage and support their child in developing self-advocacy skills. And these last two that I want to highlight are some of the most important pieces of our work. And it's encouraging secure attachment with parents and family that we want to increase. We know that this secure attachments increases a child's self-esteem, which leads to resiliency and self-efficacy, a child's belief in oneself. And then we want to strengthen protective factors. We want parents to gain parental and child resiliency. We want them to maintain connection to social supports, understanding of parenting and child development issues, and accessibility to resources. I want to thank you for your time. And next, Natalia will be sharing her journey and how her parents encouraged some of these pillars of character, building self-esteem, fostering independence, self-advocacy skills, and her own story about resiliency. Thank you.
Thank you, Elva.
Natalia, you're muted.
There's,
We're good. Can you hear me now?
yes.
Awesome. Okay, that's a good thing to do. Thanks, Elva. So my family has been part of the retinoblastoma community since 1992, and we've received so much support from the community over the years, and I'm really honored and grateful that I can speak to a topic that's close to my heart today. So I was diagnosed with retinoblastoma in 1992 when I was 18 months old, and my family and I lived in Poland at the time, and treatment wasn't very advanced there. So my parents packed up myself and my 4-year-old sister, and we moved to Toronto, to Canada, where Dr. Brenda Galley and her team at Sick Kids were waiting for us. So my left eye was promptly enucleated, and I had chemotherapy, laser therapy, and cryotherapy on my right eye for about 2 years. And now I have 20/200 vision in my right eye, and my left eye is artificial. Now I'm 30 years old. I live in Peterborough, Ontario, Canada, with my husband. So when I think about the term retinoblastoma survivor, I often have a hard time identifying as that, and it doesn't really fit for me. And after doing some thinking and reflecting, I realized that it's because I see my parents as retinoblastoma survivors. I have very little memory of the treatments I went through. Most of the memories I have are really fond memories, actually, of Sick Kids, like the colorful footprints on the floor in the main lobby and hallway, the really warm and inviting waiting rooms, and the incredibly generous and kind staff that we encountered. And of course, the cafeteria at Sick Kids, which we always went to every time we visited, which was one of my favorite things. I also have some memories of being bullied as a child, being called names, and having a hard time keeping up in gym class with some of my peers. But really, when I think about my childhood and upbringing, the overwhelming feeling I have is that of warmth, adventure, and feeling limitless. And be it conscious or unconscious, I feel that this was my parents' strategy, and it was to instill 3 really pivotal qualities within myself, which were resiliency, fostering independence, and advocacy. And I think that they were incredibly monumental for me to get to where I am today and how I move through life. So what I'd like to do is I'd like to share with you 3 stories that illustrate those 3 pillars that have run through my life. The first one is when I was in elementary school, probably grade 6 or 7, when some of the intermediate students in the school were making fun of me and calling me names like Cyclops, Plastic Girl, Fake-Eyed Girl, things like this. And I immediately told my older sister. My sister told my parents, and my parents sat me down and asked me about what had been going on. And they said that they would connect with the teachers at the school. And soon after that, the Canadian National Institute for the Blind, the CNIB, visited the school, and they hosted an education afternoon for the intermediate classes at the school. And what they focused on was teaching us about vision. They brought in a cow's eye that they dissected and taught us about the different parts of the eye and what they do. And they also had some teaching around how our other senses become heightened when our eyesight is compromised. And at the end of the afternoon, the students were able to ask me any questions they had, and they did, and that was the last time I was ever bullied. Now reflecting on that moment, I realized that what my parents and and the teachers modeled for me was that in the face of adversity and pushback, what we need to do, or what I need to do, is become part of the solution. They taught me that fear and lack of understanding often leads to people being rude or unkind. And so in those moments, what we need to do is bring people in, educate them, and really share with them what's true for us, and often their defenses are down. And this really fostered that resiliency within me, because now to this day, when I feel any sort of obstacles or any challenges that come my way, I stay put, I lean in, and I persevere. As I mentioned, I have two sisters, one older, one younger, neither of which were affected by retinoblastoma. So my sisters and I and my parents were very active in my childhood. We did lots of outdoor activities like fishing, camping, hiking, and lots of traveling. And what my parents did is they let me go on and do things with my sisters as I would as a child. And they would hang back and kind of watch me from a distance and see how I managed. They would support me if I needed help. But really what they did is they encouraged me to ask for help when I needed it. And they coached me in creative ways to find creative ways to do the things I wanted to do, but just do them differently in a way that made sense for me. For example, when we would go hiking, I would often follow closely behind my parents. I would watch their feet to see if they were stepping over stones or roots. They would warn me if there were any branches that faced height, and they would let me know when to push them away. And this really allowed me to become independent and really feel like there were no limits to what I can and cannot do. They taught me that I can do anything I wanted to do. I just had to find some creative ways around it if it wasn't easy. And this really relates to the last point I wanted to make around advocacy. My parents often told me that I knew my story best and I knew what I needed often. And sometimes I'm going to have to be the one that speaks up about that. So the team at Sick Kids and my parents often told me about things that I should avoid, like radiation, for example, x-rays and sun exposure and things like this. And they said that often healthcare professionals don't all know about retinoblastoma, and that I'll have to be the one that comes in and educates them and lets them know what kind of things are normal for me and what things I would like them to check out. And this was similar also in school. When I moved through elementary school, high school, my undergraduate degree, and eventually my master's degree, I eventually just started approaching teachers in the beginning of class, the first time I met them, and just let them know about where I was at, what my needs were, and what I might need from them to make my learning a little bit easier. And what I really made sure that I let everyone know is that I want them to follow my lead, and that I am very capable and comfortable to ask for help when I need it. And this runs through all of my relationships, my friendships, family, coworkers, employers, acquaintances. I send them the message that I know what I need, and if I don't know what I need, I'm very happy to ask for help. So to wrap up, what I really came to speak to today was about the psychosocial impacts post-enucleation. And when I think about enucleation, it's a moment in time and it's an event that happens. But really the impact of it becomes long-term. But what was very true for me, and what I think is important for everyone to know, is that enucleation, retinoblastoma, vision loss or visual impairment is part of who we are, but it is not who we are. My parents worked so hard to make sure that that's the stance that I hold, and I believe it truly, and it's really helped me to become a strong, independent, and successful woman who happens to be visually impaired and have visual impairment. So what I'd like to leave you with, parents, is I know that this is often an uncertain and scary time. I would say lean in, feel all the feelings, don't feel like you need to know everything, and just have fun, bring your kids into the conversation and be part of the solution. And those kids and adults out there who have had retinoblastoma, you're creative, you're brave, and just remember to continue being brave and continue having fun and be limitless, because that's really what survivorship is all about. Thank you.
Okay, should I just start?
Yes, Monica, you're up next.
Okay, well, thank you very much for having me. I was very impressed, Natalia, by your words. I have a daughter who has bilateral retinoblastoma, so you're my courage maker today. Thank you for that. Yeah, I'm talking to you as a mother, as I said already, as a founder of a foundation for children, parents, and survivors of retinoblastoma. I was quite impressed to hear about the long experience you have in Canada, and that's not the case in Germany. When we found out about our daughter's disease, there was nothing for parents, kids, survivors, or anything like that. So that was 10 years ago when we started CACS. Yeah, and the third thing I would like to say at the start is that I'm a strong believer in the strength of our children, and if I see Natalia, I think I'm on the right track. So my task was to talk about how parents explain retinoblastoma to the patient and their siblings. This is a very emotional topic for me, of course, and maybe something very important to say is that I have the feeling that it is the patient, our children, that give us the pace on how we answer the questions and when we answer the questions that they have. My English is not that good like Natalia. You were very strong and Elva talking, so I'm trying to find the right words. But what I want to say is that I think you always have to be very honest. Of course, we are as parents confronted with questions that we don't want to answer, to be honest. I mean, if the child is small, 2 years old, it will ask, well, I want my eye back. Where is my eye, and why is my eye like that? So the first honest answer is that the eye will never come back. So I am a very strong believer in being honest. On the other hand, you always have to have a look at how can the child handle the information. You don't want to scare your child. Can he or she really understand what you are telling them? But I think that children ask the questions at a time when they can take the answers. There was a nice encounter about 2 weeks ago in our kitchen when there was a retinoblastoma survivor who visited us. He is a bilateral survivor, and he's a very good friend of ours. And he came and had his little baby girl in his arm. And then were talking to each other, and then he said his name is Hans. He's quite famous in Germany now in the retinoblastoma group. It would be very nice for him also, I think, to meet all of you at some later point. And he told me that he's so lucky that his daughter had not inherited the disease, and that his child did not inherit retinoblastoma from him. So our daughter was standing next to me, and she said, well, is there a thing that I will maybe inherit the disease to my children? And so that was another very tough question to answer. And I said, yes, if there's a 50-50 chance that you will pass on the disease if one day you will get a child. And so we had a very good, very deep talk, but it was very special. And in the end, for her, with 14 years old, she said that Hans has a healthy child, so maybe she will have a healthy child. But I think that it is very, very important that the child can build up trust in your answers and that you are honest. The other question that always comes up with our 14-year-old, I think she's still very young to ask those questions, and that is that she asked if she has a higher probability of getting cancer again. That was what Natalia said. That's a topic that comes up when we are talking about having an X-ray or stuff like that. I'm trying to teach her that she has to take care of herself. I'm trying to teach her to take care of herself, and in doing that, I have to give her the right information. So I have to tell her that she has to avoid radiation, avoid sunburn, and all that kind of stuff, because she has to avoid or reduce the risk of having a second cancer. So we're talking about that, and again, I want to tell you that I think it's very important to be honest. Another thing that was very, very important for our way to communicate the disease to our child was that we had very exclusive time. I think that the time issue is a very, very important one, because the questions that are being asked need time to be answered. And sometimes you even have to think about your answer, because it takes some time, and it's sometimes not easy to answer. So we take very, very exclusive times with our daughter. She's the youngest of 3 daughters. So we're going into the siblings talk as well. I'm trying to be a little, I hurry a little bit, but so we try not only to take exclusive time for our patient daughter, but also for the siblings also. I thought that that answering questions was much easier, explaining the disease, which was much easier when having retinoblastoma survivors like you, Natalia, with me, and Camilla, our daughter, grew up with a group of about 20, 30, 40 retinoblastoma survivors. And she's a very strong young lady, even though she's in the middle of puberty. She is a great girl, and she has. Today I asked her, "What do you do when kids bully you?" And she said, "They don't do that." And I said, "Well, why don't they do that?" And she said, "Because children that bully me, they are the ones who have the problem. I don't have the problem." So she's a very self-confident, and I think it's not our merit of my husband and me, it's the merit of the older retinoblastoma survivors that have been with Camilla from day one of her diagnosis. And I'm very, very, very thankful to that group of people who is so very precious and knows exactly what life is all about. So I'm very much advocate to build a small retinoblastoma community in your area. It doesn't have to be a big group. It has to be a small group. Also, kids same age that grow up with their child. I would like to, because I'm seeing the time passing, I did everything in written form as well, and I would be happy to share that with you. But I would like to have a few words on the siblings. We at CACS have put a very strong focus on siblings from the first day on, because I could see that the focus on our ill daughter was very easy to find, but it was very hard to find the focus for the healthy children. And to make a big jump, both of our daughters, who are much older than our youngest daughter, they have. One of them is a pediatric nurse and now is studying medical medicine, and the other one is studying psychology. So you can see what has been going on in their mind, and it has very much influenced their way of dealing with their sister's disease. I want to give you one situation which was a key situation for us. When we got the diagnosis, we decided that we would take each sibling separate so that they could react separately on what we were going to tell them, because they are very different personalities. So we took one daughter and told her, and she started crying, and she said, this is so terrible, and she asked all these questions, what this would mean. And the other daughter, who is just as wonderful as the first one, she said, "Oh my God, I'm so glad I don't have that." So it was, and it was great because they were young, and it was just good that they could react and were allowed to react the way they needed it. So we have gone on to that and have tried to allow every reaction and to have exclusive time with these two girls as well. I have, how can I explain that? We have allowed every feeling. Oh, what is this? Why is this off? I don't know. Do you still hear me? Okay, so I'll just keep on talking. We have tried to allow every feeling that they wanted to have, and we have tried to explain every bit of the disease to them. We have gone on. I think that on one meeting with siblings, we had a psychologist talking to. We had a siblings group of about 20 siblings, and we asked them to write a letter to their parents so they could tell us their feelings, if they felt neglected or if they had something to tell us. It was anonymously, so they could write a letter to their parents and say, what is it that you want to tell your parents? And it was very, very amazing because all of them wrote us a letter that they didn't feel neglected, that they felt that the time that we needed with the ill child was very important also for them, that we spent this time. It was okay for them to spend more time with the ill child. It was very good to give them a chance to write all that down. And it was anonymously, so we didn't really know which letter was from which child to which parents, but it was very interesting that all of them were very touched by the fate of their ill sibling, and that it was okay for them that it had a special role in the family. So I really advocate to put siblings together and to have them talk to each other, because I think that they go through very similar experiences. Yeah, I see that my time is already over. I've talked 12 minutes, so I'm stopping now. But I left home. I'm in the front of the hospital because my father-in-law is in the hospital, so I have to go in. I'm so sorry, but I didn't want to quit again like last week when I was ill, so we are having some problems here. But when I left home, I asked Camilla, my daughter, what do you want them to tell them about your life motto? And she said, well, you could tell them, make every day the best of your life. So I would like to tell you that I'm very happy because it was Camilla that sent me on this journey, and that gave me the possibility to meet you. And I have to tell you that I'm very, very grateful. And I think it's incredible what you have organized here. And I really wish that we stay in contact, because I think that we can be much stronger together. So thank you, Natalia. Thank you, Elva. And I look forward to hearing from you, Philip. Thank you for your attention.
Monica, thank you so much. That was beautiful. Take good care.
Thank you.
And I hope you feel better. Okay,
I do.
Philip.
I do.
All right, Philip, you can.
Thank you very much, Elva and the team. My name is Philip. I'm a patient support manager for Aja Cancer Support Trust, and I'm presenting from Nairobi. We work at Kenyatta National Hospital, which is one of our major referral hospital in Kenya. So most of the retinoblastoma patients who are diagnosed in Kenya, most of the times end up in Kenyatta National Hospital. But of course, with the time, we have other referral hospitals that are coming up that are seeing a lot of retinoblastoma patients. But our focus and the focus of my presentation are the patients that we see at Kenyatta National Hospital. I'll give a brief about cancer, childhood cancer. As you can see, retinoblastoma does not really feature that much because the cases are not that many. They are there, but not many compared to the other cancers like leukemias, Hodgkin's lymphomas, and Kaposi sarcomas. I'll focus a bit about the challenges that children with cancer face in Kenya, and probably these are some of the issues that you'll find across low and middle income countries. One of the major challenges that we face, and this is important because it's going to impact on our psychosocial support that we give to the kids. So you find that most of the time, they really take a long time. They lag time from diagnosis to the treatment. It takes a long time before someone ends at the main national hospital, 6 to 30 months max. And then, of course, so what then this does is we find that we have a lot of cases diagnosed with retinoblastoma and other childhood cancers. There's late presentation, which of course we know and we understand has really negative impact on the treatment outcome. And then this also then affects the survival rate of kids with cancer compared, of course, to children in high-income countries. And one of the things we even face in Kenya is you find that we don't have appropriate pediatric palliative care. So these grim statistics, of course, then affects the work that we do, which is basically at Kenyatta National Hospital. On level, it's a ward called 1C. And we find that in 2008, we found that childhood cancers accounted for 15% of childhood cancer admissions. These are very scarce figures. I don't think it's a reflection of what is happening totally in the whole country because we've never had a countrywide cancer registry. And then you find that most of the hospitals we have, including Kenyatta, there's lack of dedicated pediatric oncologists and, of course, specialists. And I think this is not something that just happens in Kenya, but of course it happens across African countries. For the last 5 years, there's been a bit of development. We are having a lot of young people taking up oncology as subspecialty, and we're having more of young people being trained. So we find, again, that only 2 in 10 children diagnosed with cancer will survive in Kenya. This really has, of course, an impact on what are the psychosocial programs that we're able to offer to these kids. So as we try to meet the psychosocial needs of the families who are in the hospital, sometimes the needs are more practical than psychosocial because they come to the hospital. Sometimes the parents don't have transport to come to the hospital. Sometimes when they come to the hospital, they come unprepared. Probably they were coming and they are told you only take 1 week, and then they end up taking longer time and they don't have funds to sustain them within the hospital. So this, of course, means that instead of me offering that support, the support they need at times is a practical. I need you to help me with maybe airtime to call somebody at home, because most of the times when they come with the children, there's that one child who is sick. And then you find that they might have 6, 7, or 5 other children that are left at home. And most of the times in the African settings, it's the mothers who stay with the children. So the mothers have to take care of the one child and, of course, the other siblings who are at home. So the activities that we do, besides the practical needs, we also give them a bit of distractional therapy. Basically, we help them to make beads. This helps with the, of course, sensory motor coordination for those who can be able to do it. Of course, also distracting them from the pain and the disease. And then when they make something, there's that a lot of self-confidence that is built and self-esteem. Oh, look at what I've made. Oh, look, I can do this. And sometimes we also engage the parents in this process, because most of the parents are there. They don't carry books to read. They are just there and they're sitting, and there's not much that they're doing. So this gives them an activity to take their mind away from pain and the child. So, and then of course, we are also engaging a lot in therapeutic arts. And these are activities that we do in the retinoblastoma ward. We find time to engage in expression. Sometimes we engage the parents also, so the parents work with the child. So that's a way, again, of distracting their mind from what is going on. And of course, as we engage them with these therapeutic arts, you're also trying to enhance their skills. If you help them develop coping skills, we help them even with the body awareness, because the craft activity is centered in a way that it tries to focus on helping them with the body image issues. And these are mostly children who are younger, slightly younger. And also for the parent, it's a good way of communicating with the child. So sometimes children, and more so in African setting, children do not have that capacity to vocalize, because growing up we were told children are there to be seen, not to be heard. So they're not very expressive. So art therapy is a good way of really trying to make them expressive. We also engage in music therapy. Basically, it's a non-pharmacological way of making the parents have fun, but as they have fun and the kids also have fun, it's to distract their mind away from the situation in the hospital, from the surgery that is coming up, from all these things that they are facing within the hospital setting. And then, of course, we also have symbolic play. Symbolic play basically helps us to connect the child with an upcoming procedure. We help to connect the child to bond, have that relationship with the doctor. You know, they can play doctor and do all these things. And sometimes also helps them to desensitize them from the procedures that are coming up, and becomes a very appropriate way of telling them or preparing them for the procedures that they are going to have. So what's the way forward for us? There's a lot of challenges, of course, that we face in offering this support, because like I mentioned, we are at the stage whereby the needs are so enormous. As I've said, we have patients who come in. When they come in, they come in with late stage presentation. So of course, we have to address the late stage presentation. Some of them become more at a palliative stage, so that needs to be addressed. There's a lot of illiteracy among the parents. So what we do is, I didn't put it here, but we have a support group for the parents. And it's basically educating the parents. What is retinoblastoma? So we educate them, we talk about it, and the challenges that they face. And it's really interesting that when you listen to the parents, the stories and the issues that they are facing, the way they are being accused by the other partner, oh, you are the one who is responsible for this. This thing runs within your family. So there's a lot of things that also brings in family tension between the parents. So we try to educate them and help them. Actually, at times we go as far as calling the other partner and telling them this is what retinoblastoma is about. So changing really that stigma. The other thing is we've had young people who are who are teenagers, and then there's the issue of bullying. So you again have to reinforce that sense of self-resiliency and trying to help them, prepare them. You know, once they finish with a long hospitalization, when they readjust back to the community, they need to have those skills that will help them to even do better in the community, because the challenges are there. And then the other thing is, of course, is we are also trying to work on developing, and this is still in its formative stages. I've been running this program for the last 5 years, so it's still initial. And we are looking at how can we be able to have specific retinoblastoma-focused psychosocial intervention. So that's work in progress. And of course, I'm really looking forward to hear from others throughout this conference and see how can we be able to work together. Maybe we can learn from our counterparts, from Elva, of course, from Natalia and other organizations, how we can have clear, structured psychosocial programs, of course, with the limited support, because all these things are donor dependent, you know. And then, of course, we really need to focus on increasing education initiatives. Stigma is something that is really keen in this area. We need to educate people, and I think there's been some developments that have happened in Kenya, of course, through Sick Kids Foundation and other organizations that have been coming to Kenya, including BASIS, IFAN, and there's so many organizations that have been doing that. But I think there's need to increase that in the country, and not just in Nairobi, but across the whole country, so that these cases can be diagnosed early, and then, of course, then treatment really becomes possible. And the last one is, of course, we need to really focus a lot more on community education, because that lack of education brings in misinformation. Lack of appropriate knowledge also fuels stigma. And of course, when stigma is there and when there's no information, then that's where we have cases of kids being called, they have evil eye because of retinoblastoma. And evil eye basically means is somebody who has something bad about them. They, the way they look, they have this evil eye. And this really affects many kids. And then there are parents who also do not bring their kids to the hospital, or do not take their children to the hospital. They take them to the herbalist, they take them to the witch doctors and traditional medicine men, who will then give them herbs that will cure the retinoblastoma. But of course, this does not help. It just makes matters worse. So I think with appropriate education, community education, people will know that this is a biological issue, and that when you go early, it's treatable and it's curable. So thank you very much.
Well, thank you very much for such a thorough and engaging panel. This is Caitlin. I'm moderating the Q&A session. We only have a few minutes before we start our child life session, and we are committed to staying on schedule today. So I will raise one or two of the questions that we received, and others are encouraged to stay for the networking session, where you could ask questions of others as well. So one of the questions we received is from Genevieve, and her question, I believe, was for Natalia. And she wanted to know who facilitates the life survivorship programs, and what specialists or diagnostics are available through this program.
I feel like this question might be for someone else, because I'm not sure necessarily. I'm not sure if someone else can help me
Elva,
out.
I'm so sorry, it was for Elva.
I'm like,
My apologies.
No, it's all good. Whew, off the hook.
Natalia, I think from experience you'd be able to answer this. So, later in the day, all of you will be meeting Marissa, most of you know very well, as well as Dr. David Fryer and the rest of their panelists. But here at Children's Hospital Los Angeles, we actually have a life survivorship program, and again, it is based on an interdisciplinary model. And so you have a whole list of multidisciplinary professionals who are part of the survivorship program. And this is usually the time, as I mentioned earlier, that we like to transition our young teens into life survivorship programs so they can begin to learn more about self-advocacy, as Natalia and both Monica spoke about in their own experiences, about learning about some of the risks associated with having the diagnosis of retinoblastoma. And so this is where young teens can then begin to become more educated, take responsibility for their own care as they enter young adulthood, that they then can transfer this to become someone just like Natalia and Monica's daughter, Camila, who are definitely able to advocate for themselves. So the life survivorship program may look different in other countries or in other parts of the States, but here at Children's Hospital, if you stay on and join the session with Marissa and Dr. David Fryer, you'll learn much more about it.
Well, thank you everyone so much for this amazing session. I found it very informative, especially as a parent. So all of you who presented. I really enjoyed all your presentations. Now, for our next session, we're doing the child life activity.